So now we're going to discuss the immediate effects of LANAP in vivo on human chronic periodontitis microbiota. So this is an in vivo study in real humans. So we have to have, we presented this last week at the American Academy of Perio meeting in San Francisco twice. So we have to have disclaimers that these are my opinions that don't necessarily reflect Nova or Tempo or Tom Rams, and I teach. Also, it's important to note that the content of this presentation was not subjected to any input or prior approval from Millennium Dental Technologies. They didn't even know I did this study until after I sent it to them, after I presented it at the American Academy of Dental Research meeting in March. So, independent completely. So, let's talk a little bit about the periodontal disease, traditional therapy, again, focused on the result. And today, and later, we've added dental, alternatively, people added dental lasers, various dental lasers, mostly Nd:YAGs, so studies then, there have been a lot of meta-analysis of laser studies, and what they concluded, and you'll hear people quote this, the literature review supports that there's no evidence to support the superiority of the Nd:YAG laser over traditional modalities of periodontal therapy. So you're thinking, well, wait a minute, this laser is not working very well. Okay? And here, wait a minute, oh dear, here's another meta-analysis, 2014. Our findings are in agreement with those of previous systematic reviews that found insufficient evidence in the literature to support the adjunctive use of Nd:YAG laser to scaling and root planing. So people say, well, see there, just as I thought, the laser doesn't work.
Snake oil.
What?
Snake oil.
Snake oil, as Steve said. However, they were comparing apples with oranges. They were not looking at the LANAP protocol. So, when you add the LANAP protocol developed by Greg and McCarthy, it changes what's going on. That's a newer therapy. And so that therapy focuses, again, as Steve said, on the pathogenic subgingival microbiota. And that's what we're going to talk about today. So my mentor, he talked about his mentor, was Jerry Kramer. And he said that the restoration of destroyed periodontium by new cement and periodontal ligament and bone is the holy grail of perio. And certainly we know that. And he trained at DU. But he also pointed out that Yuckman and Evans said that favorable clinical and regenerative histological changes have been noted following use of this laser-assisted new attachment. 13 out of 16 got new attachment. So that's pretty impressive. But the antibacterial effects of this LANAP surgical protocol on subgingival plaque have not been studied, which may contribute to this favorable treatment outcomes. So back in '92 I did a study, but I kept waiting for somebody to do a study. You know? Some university, but they never did. So finally I said, you know, like anything else, it's going to be, it's up to me. So I did it. But the reason I got interested in lasers to begin with, and Steve pointed out that the laser produces high peak pulse powers, all right, and 1/10,000th of a second, you know, 100 millionths of a second produces up to 1,000 degrees centigrade and up to 2,000 watts. So when I started reading about lasers back in 1989, I said, could you put a laser in a pocket safely? If you could, wouldn't it be a real possibility that it could kill bacteria? Because then we were irrigating with all kinds of things, but what's better to kill bacteria? Heat. So now we have heat that you can safely put it in a pocket. So back then I decided to do a study to see if in fact it would kill the bacteria down there. And that was in 1992. And we did it with Cobb and Cloyd, Kansas City. 11 teeth were treated, first by root planing, then by various laser protocol. We extracted the teeth. These were teeth that were, in those days, would be extracted. We might even try them today. All roots, we did SEMs, had some residual calculus, and laser-treated calculus deposits were free of their characteristic surface layer of microbial plaque. As Steve mentioned, so here's what we found. It removed the smear layer. Here's a piece of calculus. As Steve said, we think that it alters calculus, so wouldn't you say that looks like altered calculus to you? And it dehydrates it in a way that we think that it comes off easier. Not necessarily always easy, but easier. All right? And there's no bacteria left on the calculus. So we know that with any therapy, we're leaving some calculus back in there. So that's the other argument. You're leaving calculus behind. But we think that we've disinfected it such that we can get new attachment, even with some specks of calculus left. So the study, this showed elimination of AA, PG, and 8 of 11 laser-assisted, laser-treated teeth. So, and the conclusions were that these microbial pathogens appear to be severely altered in vivo by subgenital laser exposure. And the conclusion in the study, it's not surprising that the subgenital microflora were suppressed and suggestive of a potential specific use of the laser for removal of bacteria from infected pockets. So, at least back in '92, we thought we had some possibilities here. So why is this important? Well, we talked about it because scaling leaves the bacteria in, but there's many studies showing that after scaling, right after, there's lots of bacteria back in the pocket. And here again, this group, subgenital mechanical cleaning in itself has a limited effect on actually removing bacteria. So if we could, it would be a breakthrough. And here's it showed, immediate post-instrumentation, all those bacteria we talked about, still there. And here's a study with Sukransky, all right? They had 17 periodontal patients. They actually sampled about 1,200 sites, okay? Still DNA probe positive, but numerically low. Scaling could not completely eliminate the organisms. So, I mean, we can do study after study, probably 4,000 sites. Never has scaling removed, they leave millions behind. So what I told you before, what about surgery? Well, I talked about that earlier. Surgery leaves it behind also. What happens if you leave them behind? Okay, so here's a study that showed that high bacterial counts and persistence of red complex species in pockets before GTR surgical treatment negatively associated with outcome of GTR. So if you leave them behind, so it affects your ability to get regeneration. But now, we're not leaving them behind. All right? So that's GTR. All right? So Sukransky and his group said the goal of periodontal therapy is lower levels of subgenital periodontal pathogens to those found in periodontally healthy subjects. This is necessary, so that's what we're trying to do, to get near health. However, it is necessary to first reduce the pathogen levels quickly to levels at or below those observed at health. So, you see that word quickly? So what we did, we tested right after. So that's quick. When you say, as soon as you're done, we test it. So that's why we tested right after. Right? Second, modify the habitat in terms of pocket depth and inflammation in order to maintain the pathogens at the lower levels. So that's what we get with LANAP. We get pocket reduction. Finally, lower the pathogens in non-disease periodontal sites and other oral reservoirs. Bingo, didn't I tell you about them being all around the mouth? And that's why we do whole mouth therapy, because those bacteria that we're finding in those 8mm pockets, some of them are still living in the floors. So that's why when you do LANAP, you do every tooth. Right? And you have them on antibiotics for other reservoirs. So that's it. The master of microbiology, that's what he says to do. And bingo, we can do it. So what happens in microbiology with the LANAP surgical treatment protocol? So we presented, my son actually did the presentation at the American Association of Dental Research meeting in Charlotte, March 20th. And our research team involved. I did this all in my private practice, in a busy private practice trying to do this. It takes a lot of time. My son, all this data, we had mountains of data. Try to imagine 26 cultures before and after, all the bacteria, 14 different bacteria. All right? Try to imagine then 120 different sites, you know, pockets, chartings, and then before and after, putting all those together. That's a lot of data. So fortunately, you know, he knows statistics and I don't. So he was able to analyze this data for me and helpful. And then Dr. Rams took our microbiology, he's got a PhD in microbiology, and put it all together, what it actually meant. So it was great. And at USC, Jorgen Slotz did this on a fee-for-service basis. He didn't even know, they were totally blinded. They didn't know we were doing this study. It was totally blinded, and I paid for it. Okay? So that's what it says, I paid for it. Okay? And I didn't get any money from anybody else. You know, if anybody wants to give me some money, I'll take it. But no, they didn't. So the objectives was assess the immediate post-treatment effects of laser-assisted new attachment procedure as compared to ultrasonic root debridement alone on bacterial pathogens in deep periodontal pockets. So we wanted to have a control. So if we could get it out with scaling, then, you know, maybe it's something wrong with our technique. So we had 20 of these, and we did 6 ultrasonics. Now that's ultrasonics with dilute chlorhexidine. So what we really were looking at, we also wanted to look at, Socrates look at did we get rid of the bad guys, PG and the red and yellow ones. Now, sometimes there'll be some of these left. These are normal flora. You can't get rid of everything. And when we grew out things, we might grow out some small levels of strep sanguis or something like that. But we wanted to know if we got rid of the bad ones. So our methods were 26 adults with untreated severe periodontal disease, you know, 20 subjects. Notice the similar sex and age of these groups. And 6, we did ultrasonic root debridement. So basically, the study flow chart was we took a microbial specimen, two samples. I usually took it from the mesial, facial, distal lingual, or vice versa. Wherever I wanted to get 360, so I wanted to get as far away from the other one. I didn't want to sample right next to each one. So if I found it, or mesial facial or distal facial, but I tried to go catty-corner. You follow me? So I was getting at least around the tooth. So we did that right afterwards. Lauderdale protocol, 20, ultrasonic 6. And then immediately, we did it right afterwards, pretty quick. I would sample. Again, the same sites, mesial, facial, distal lingual, or vice versa, whatever. I did the same thing for ultrasonics. So the ultrasonics, we did from 1 to 2 minutes. Right? So the LANAP protocol, Steve has gone through that with you, but basically, here it is. We started with the first pass of the laser, 3.8 to 4 watts, 150 microseconds, 10 to 12 millijoules per millimeter of pocket depth. So we were able to control how much energy we used. Like if a 5 millimeter, well, we only use 6. 6 millimeter pockets, we'd use 60 millijoules. 8 millimeter, we'd use 80 millijoules. 9 millimeter, we use 9 millijoules. 90 millimeter, follow me? Okay, then we did ultrasonic debridement. All right, 75 power, 60 seconds. In this study, 60 seconds with, again, with chlorhexidine irrigant. And then finally, the second pass, again, 3.8 to 4 watts, 65 microseconds, 650, 4 to 5 millijoules per millimeter. So total laser dose was 14 to 17 millijoules per millimeter of probing depth. So we controlled the energy based on the pocket depth.
Could you go back 1 slide, please?
That one?
Yes.
Okay.
Thank you.
So the ultrasonic was, we used the piezoelectric scaler. P1 scalar tip ultrasonic root debridement was performed for 60 to 120 seconds per tooth. And then This shows how that's not how we cultured. I usually cultured this side and then the distal lingual, but I couldn't show it. You know. So I sampled 2 specimens before and after completion. All right. And the mean probing steps were 7.4 and Lanap, 7.7 and ultrasonic. So essentially the same. And the range 6 to 11, 6 to 10. So up to 11 millimeter pockets were sampled in this case. So we're talking, this is the real deal here we're testing, you know? It's not 4s and 5s. Right? So our methods we used were performed by personnel that were blinded to the clinical status of the study subjects, the nature of the periodontal treatment, and their inclusion in the present analysis. They didn't know we were even doing the study. So everybody was blinded, including me. You can see I'm pretty blind. So anyway, my assistant helped me. So the results, immediate post-treatment effects of the Lanap protocol. Right. So 17, on a subject basis, 17 of 20 tested were culture negative for all evaluated bacterial pathogens in immediate post-treatment subgingival samples, 85%. So that's never been shown by any study, by any therapy ever before. You can irrigate all you want with betadine, you can scale all you want, there's still plenty of bacteria. Here's what it looked like. You can see that we got rid of PG, we got rid of practically everything. Now these are the 3 that still had a few bacteria left, all right? Now these are hard to get rid of, but we had those 3 bacteria were in 3 patients. So here's what it looked like, pre and post, all right? You see, pre we had lots, post we had none. Pre we had lots, post we have none. Pre we had lots, post we have none. Pre we have lots, post we have some. Okay? And 3 of them. Okay? So that tells us that at least our technique was sensitive. If they were positive, perhaps they were positive. It wasn't we were just, if they were all negative, you'd be suspicious. Maybe I cooked the books, you know? So immediate post-treatment effects of ultrasonic root debridement. Okay. 5 of 6 treated remain culture positive for almost all subgingival bacterial pathogens detected at baseline in immediate post-treatment subgingival samples. So here we go. You can see the difference here. Post-ultrasonic, a lot blue, more blue. So those bacteria are still present. And here we get, before we had bacteria, after we had bacteria. You got it? Before we had bacteria, after we had bacteria. And this last subject, before we had bacteria and after, we got rid of most of them except for beta strep. So we did 6 because they were all coming back positive. And I ran out of energy. Conclusions. Right? The Lanap treatment protocol, but not conventional ultrasonic root debridement, immediately suppressed bacterial pathogens below culture detected limits in most deep periodontal pockets, 17 out of 20. We did. And also, statistically significant reductions in subgingival occurrence of red and orange complex bacterial species were detected in deep periodontal pockets immediately upon completion of the Lanap protocol, but not after ultrasonic root debridement. Now, I talked before about the red and orange are the bad guys, so we got rid of them. Okay, so now you can speculate, as Steve did, and I am too, that the immediate and pronounced subgingival reductions in red and orange complex bacterial species in most deep periodontal pockets likely contributes to the favorable clinical, radiographic, and histologic outcomes reported by others, Yuckna and Nevins and others, using the Lanap treatment protocol. So that's our hypothesis, that getting rid of the bacteria gives it a chance for these bacteria for the tissue to heal in a better way. They're healing against a disinfected root. Okay? Before, they're healing with lots of bacteria in there. Okay? Yes?
Question is, when Ray Yuckna first devised this, it was essentially an evolution of an ENAM procedure, excisional new attachment procedure. And the fact that the bacteria invaded into the periodontal tissues up to 4 millimeters. So the catch is you've cleaned off the bacteria against the tooth, but how do you know there's not a harbor of residual bacteria in the tissue that can now, let's see, it's a vacuum, let's go for a free-for-all, just reinfect?
Well, we don't know for sure, but we do know that the laser will go up to 4 millimeters into tissue. That's been shown by David Harris. So we think that we're killing them pretty good, all right? So, but we don't know that. So let's look at some additional follow-up data, all right? So we actually reprobed these people, and then we had 59 sites that were 6 millimeters or greater, and we got 3.1 millimeter pocket depth reduction. Now that's superior to any scaling study ever reported. All scaling studies showed no more than 2.1 millimeter pocket depth reduction. Then we wanted to look at, we recultured at a mean time of 7.5 months, so this is a question that, so the bacteria come back, right? So here we go. So most of the bacteria didn't come back. In fact, PG, PI, 5 out of 7, they were still gone at the mean time of 7.5 months when we recultured. Now that's rarely shown by any other technique. Right? Now these patients were on antibiotics also, by the way. So the question before us, though, is still, okay, this is a nice theory. We say that we're killing the bacteria, and if we kill the bacteria, we should get better healing. But the question before us, does it work on patients, our patients? Because how many theories have you heard that when you finally try them, they don't work, right? So we tried it. And Steve showed you this case. And this case is 14 months post-op. But, you know, a lot of people would argue, well, you could get that with scaling and root planing and maybe some regenerative techniques. Let's look at some other cases of mine. So here's a lady who came in, age 84. She had 10 to 12 millimeter pockets in most areas. She was told she had to get these teeth out. Well, she was 84. She didn't want to have a denture. I don't know why, but she didn't. So we said, well, let's just try the nap. So here she is 1 year later. So now we have 4s and 5s. Now I know that since I trained at BU, we want 0 pockets. So 4s and 5s, you know, I mean 12 to 4, that's not good enough, really. So we continued to follow her, and here she is 4 years later, now at 88. Now we got her down to 4 millimeters. So, you know, we'll keep following her. Maybe we'll get them down to 3. Who knows? But that's 4 years later on a lady who was 84 when she started, with teeth that were ready to fall out. All right? And then we looked at the furcations here. So here's the before. Here she is 4 years later. Now, you can say that the x-rays are different, but at least you can see that we've stabilized the furcation at worst. All right? So here's another one. This is one of the first implants I did. All right, that's a pre-treatment. Those are 15 millimeters. So that implant was not loose. Right? We thought it should be, but it wasn't. A little bit hold it. You know how implants are. So we said to this guy, let's try something. It's not going to work, but let's try it. So here he was, actually 2.5 years later. All right? So here I had 7 millimeters. Some people asked me, that was 15 before, so we did retreat that one and got it down to 4s and 5s. So let's take another look. So here's a case that came in. This lady was so infected that initially I couldn't probe her. I had to probe her when I had her numb. She had so much pus in her mouth that, and was so sensitive that I couldn't even probe her. So that's what she looked like to begin with. Those are 11s, 8s, and 9s on these implants. And here she is now, okay? This is holding up for 2.5 years, 4s. So, and here we did culture her and put her on antibiotics, and you can see the culture, and she was genotype positive, by the way. Right. So Steve showed you this, how we got new bone on this, all right? 2.5 years later, still holding. He didn't show you the posteriors. 7 to 9 here, okay? And 3 to 4 on the posteriors. So the 11s with the 4s, 9s with the 4s, and that's new bone. So You know, when I showed this case for the AAP, they didn't believe me. They said, no, we don't believe you did this. You photoshopped this. It's garbage. So here's August 5th, 2014. The dentist who referred her says. So I had to get this data. Really, they weren't going to let me use it. I have seen Beth following periodontal therapy with Dr. McCawley and found the results truly amazing. The results obtained were absolutely remarkable, quite a dramatic turnaround. I've seen this patient several times, and currently the pocket Fs are normal with no bleeding. The case is maintaining well. So there you go. So they said, okay, you didn't cook the books. I would, but they caught me, so I had to get it done. That's the wrong button. So here's another case. Now this is hard to read, but these are 7, 8s, 9s, 10s, all throughout the mouth. All right. So I want to show you a case afterwards, so you can see lots of blacks and very few. This is after 10 months later. That's the case that Steve showed you that we had 10 months later. Went from 9 to 11 with radiographic improvement. But the whole case improved. You know, this was just part of a whole mouth therapy, just happened to have an implant in there. So let's take a look at a tooth here. So this happens to be a canine. So this person had 14, 14, 15 here on the lingual. So how are you going to treat that one? Apically repositioned flap? Okay. He didn't want to lose this canine. I don't know why. But anyway, he said it probably showed, but he smiled. So here he came back, and the pockets were 3s and 4s 10 months later. So like you, I didn't believe it. My hygienist actually did the probing. And of course, I don't trust these hygienists. I need to probe it. So I said, you must have missed here somehow. So the guy worked 7 days a week. It took 4 months to get him back in. So here we are. We finally got him back in. We put the probe in, and it was 3 millimeters. Of course, now remember, I very lightly probed. In the 4, I was really pushing. But anyway, it's a 3. All right? So these are the kind of things you can do. So based on histological work of new attachment, regeneration that Nevins and Yuckman have done, and my clinical studies and my clinical reports, I think that this is a new breakthrough in periodontal therapy. But that's for you to decide. Thank you very much.